Okay, let's unpack this.
Let's do it.
The subject today is one of the most complex, systemic, and I think often misunderstood autoimmune diseases in the entire field of rheumatology.
Absolutely.
Systemic sclerosis, or SSC, but most people probably know it by its more common name, scleroderma.
And that name, that Greek root, is really our starting point, isn't it?
It is.
Scleroderma comes from scleros, which means thickened or hardened skin.
Sounds simple enough.
It does, but you have to understand, and this is critical, that while that visible skin change is the clinical hallmark, this condition is far, far more than just skin deep.
Absolutely. We are talking about a chronic multi-system disease. It's really defined by two devastating processes that are happening body-wide.
Right.
First, there's widespread vascular dysfunction, so damage to the small blood vessels. And second, progressive fibrosis.
And fibrosis, just so we're all on the same page, is the excessive, really abnormal synthesis and deposition of collagen.
Collagen is what gives our tissues structure, normally.
Exactly, it's the scaffolding. But in SSC, the body just can't seem to turn off the building process. It just keeps depositing this tough, rigid material.
So it's essentially turning soft tissue into something rigid.
Precisely. And not just in the skin, but in critical internal organs. We're talking about the lungs, the heart, the kidneys.
Our mission today is a true deep dive. We're going to be synthesizing the clinical presentations and the really complex mechanistic data.
The goal is to give you a clear, structured understanding of two critical things.
Right. First, why is this disease so incredibly varied, so heterogeneous from one patient to next?
And second, what does the absolute latest research say about its complex origin? What are the surprising triggers that, seem to flip the switch?
Okay, so to start, let's look at the foundation of the disease. I know physicians often describe this using a few core pathogenic mechanisms.
Yes, traditionally we talk about three pillars.
What are those three pillars that really define the pathogenesis of SSC?
Okay, so pillar one is immune activation. This is the breakdown of self-tolerance, where the body's own defenses mistakenly attack its own tissues.
Classic autoimmunity.
Classic autoimmunity. Pillar two is vascular damage. This is the ongoing injury and dysfunction of the microvasculature, so the small arteries and capillaries. And pillar three is that excessive fibrosis we just described, the uncontrolled, persistent laying down of collagen.
That feels like a very clear cascade. The immune system starts the fight, the vessels suffer the damage, and then the fibroblasts just run away with the scarring process.
That's a perfect summation of the traditional view. It's a great way to think about it. However, modern research is increasingly pointing toward a potential fourth pillar.
A fourth pillar?
Yes, and that is an aberrant tissue damage response.
Okay, what does that mean? An aberrant tissue damage response?
It suggests the underlying issue might be driven less by that initial inflammation and more by a persistent, faulty tissue injury signal.
So wait, instead of the damage simply being a result of the inflammation, the ongoing damage itself becomes a driver of the disease. It feeds back on itself.
Precisely. This response is driven by things we call DAMPs. That's D-A-M-P, damage-associated molecular patterns.
Damn.
Think of DAMPs as the body's molecular fire alarm system.
Okay.
When tissues are injured, they send out these specific molecular distress signals. In SSC, that alarm system seems to be permanently stuck in the on position.
And what's keeping it on?
It could be activated by factors like hypoxia, so low oxygen levels in the tissues, which is a direct result of that vascular damage we mentioned. It's a vicious cycle.
This complexity in the mechanism, it's really mirrored in the clinical classification, isn't it? SSC isn't just one disease.
Not at all. It's classified primarily based on the extent of skin involvement, and that is a massive predictor of the patient's overall course.
That classification is vital for prognosis then.
Absolutely vital. We break it into three main subsets. The first and the most common is limited cutaneous SSC, or LCSSC.
Limited cutaneous. Okay, so what does limited mean here?
It means the skin tightening is typically restricted to areas distal to the elbows and knees. So we're talking about the hands, the face, the feet, and the forearms.
And LCSSC is strongly associated with those vascular issues, right? They often show up years before the fibrosis really kicks in.
That's correct. Patients in this category often have severe Raynaud phenomenon.
That's the extreme sensitivity of the fingers and toes to cold.
Exactly. And while the skin involvement is less extensive, you have to remember they are still at significant risk for a major vascular complication down the road, pulmonary arterial hypertension, or PAH.
This limited form also includes that classic mnemonic that a lot of people might have heard of, Crest syndrome.
Right, Crest syndrome. It beautifully encapsulates the limited disease profile.
Can you break it down for us?
Of course. C is for calcinosis cutis, so calcium deposits. R is for Raynaud phenomenon. E is for esophageal dysmotility, so difficulty swallowing. S is sclerodactyly, or finger hardening.
And the T.
And T is for telangiectasia, those tiny visible red blood vessels under the skin. If you see crest, you are almost certainly looking at LCS-SC.
Okay, so that's the limited form. Now let's move to the second, and you said more dangerous subset. Diffuse cutaneous SSC, or DCSSC. What differentiates this?
Diffuse means the skin thickening extends proximally. It goes beyond the elbows and knees.
So it's moving up the arms and legs.
Right, reaching the upper arms, the thighs, and sometimes the trunk. Clinically, this is the rapid progression category. These patients usually see skin changes happen very quickly.
And that speed is a bad sign.
The very bad sign. They also face an early and increased risk of serious life-threatening internal issues.
And what are those specific early risks that are tied to diffuse disease?
They are at high risk for interstitial lung disease, or ILD, which is scarring of lung tissue, and also for two life-threatening vascular emergencies: Scleroderma renal crisis, SRC, and severe cardiac involvement. And these often develop within just the first few years of the disease.
Wow. Finally, there's that truly fascinating third category. The one that proves the name Scleroderma can be so misleading.
SSC, sign scleroderma.
Sign meaning without.
Exactly, without scleroderma. This subset makes up maybe 10% of cases, but it's crucial because they display no clinically evident skin hardening at all.
None.
None. Yet they possess all the characteristic internal pathology. They can present with Raynaud, with specific nail fold capillary changes, with ILD, PAH, or SRC, but without that telltale hardened skin.
So how on earth is that diagnosed?
Diagnosis there relies entirely on recognizing those internal features and, critically, identifying the specific SSC-associated autoantibodies in their blood. It's a very subtle but very dangerous presentation.
Now let's move into the multi-system reach of SSC. I mean, the full scope of the problem and who it really impacts. We know it's a rare disease, but what are the numbers saying?
The prevalence figures are pretty consistent globally, generally around 17.6 per 100,000 persons per year. And like so many autoimmune diseases, it exhibits a really striking sex disparity.
The majority of patients are female, correct?
Yes, overwhelmingly so. The female-to-male ratio commonly ranges from 3:1 to as high as 8:1.
That's a huge difference.
It is. However, the disease expresses itself very differently depending on sex, and that difference is vital for understanding a patient's risk profile.
Can you elaborate on that?
Yeah.
The divergence between male and female presentations?
Certainly. Females who represent the bulk of the patient population tend to present more with the limited cutaneous disease, the LC-SSC, and they often have a younger age of onset.
Okay.
They also carry a higher overall risk for that lung vascular problem, PAH. What's interesting is that in women, the time interval between the first symptom, which is often Raynaud's, and the definitive SSC diagnosis tends to be significantly longer than it is in men.
So it seems to take longer for the disease to fully kind of declare itself in women. It presents initially as those more peripheral or maybe less aggressive symptoms.
That's a good way to put it.
But when it hits men, it seems to hit with greater velocity and severity.
That is exactly the pattern we observe clinically. Males are far more likely to develop the diffuse cutaneous disease, the DCSSC.
The more aggressive form.
Right, and they more frequently suffer from the most severe internal complications: the interstitial lung disease, the cardiac involvement, and the scleroderma renal crisis. When SSC occurs in a male, it is statistically more likely to be the aggressive phenotype.
And this pattern of severity isn't just tied to sex, it's also tied to race.
Absolutely. The data consistently shows that African American patients tend to experience disease onset at a younger age.
Younger.
Yes, and they exhibit more severe phenotypes across the board. They have a specifically increased risk of significant pulmonary fibrosis, the ILD, and that scleroderma renal crisis.
That's critical. It highlights that susceptibility isn't just about general immune system function.
No, it's about specific genetic pathways that, when activated, predispose certain groups to the most aggressive forms of the illness.
Okay, let's pivot to the tangible symptoms, the things you can actually see and feel. Starting with the skin. How does this process of hardening actually manifest from its earliest stage?
The skin involvement is progressive. It begins very subtly, often with what we call puffy fingers, and non-pitting edema.
Non-pitting, meaning if you press on it, it doesn't leave an indent.
Exactly. It's a kind of dense swelling. This swelling phase, which can easily be missed, is then generally followed by the actual induration and tightening, the sclerosis. The hands and face are typically the first areas involved.
And as we discussed, the distribution of that thickening is what separates the limited from the diffuse forms.
Yes, and in diffuse disease, that progressive skin involvement is not just a cosmetic issue or functionally disabling, it's actually a marker. It's associated with worsening lung function.
So as the skin gets worse, the lungs often get worse too.
They often progress in parallel. Other common visible signs include intense early-stage pruritus, which is itching, generalized skin darkening, and that very distinct salt and pepper appearance.
The salt and pepper skin. That sounds like a really striking visual sign. What is that?
It is. It refers to patches of both hyperpigmentation, or darkening, and depigmentation, or lightening. It often spares the hair follicles, which gives the skin this patchy, mottled look.
And functionally, the tightening can be devastating.
Oh, absolutely. We see sclerodactyly, which is the tightening of the finger skin, making it hard to bend the fingers, and progressive perioral skin tightening.
Around the mouth.
Yes, which leads to a decreased oral aperture, making simple tasks like dental hygiene, eating, or even just opening your mouth wide incredibly difficult.
The other hallmark, which often precedes the skin changes by years, is the vascular dysfunction centered on Raynaud phenomenon.
Raynaud phenomenon, or RP, is virtually universal in SSC. It occurs in over 95% of patients.
Wow.
It starts as a functional reversible vasospasm. The digital arteries constrict dramatically in response to cold or emotion.
Leading to those characteristic white, blue, and then red color changes in the fingers.
Exactly. But in SSC, it stops being just a functional issue. It becomes structural.
What do you mean by that?
Over time, that repetitive vasospasm and the chronic injury it causes lead to progressive structural changes in the vessel wall. There's proliferation of the internal vessel lining, destruction of the capillary bed.
So the pipes themselves are getting damaged.
Right. And you get permanently impaired blood flow. The functional problem transforms into a structural defect. This is that vicious cycle of vascular damage feeding tissue injury.
What are the worst consequences of this chronic impaired flow?
The most common severe outcome is the development of ischemic digital ulcers. These can occur in up to 50% of SSC patients.
And these are not just simple cuts.
No, these are non-healing, incredibly painful ulcers that severely impact quality of life and are highly prone to infection. In extreme cases, chronic severe ischemia can lead to gangrene and require amputation, particularly of the fingertips.
And these ulcers, they're more than just a local problem. They're a sign of overall disease aggression.
They absolutely are. The early occurrence of digital ulcers is a strong negative prognostic marker, especially when it's associated with diffuse disease and the presence of anti-CL70 antibodies.
What else do you look for?
We also look for the little clues left behind by previous episodes of ischemia, digital tip, pitting stars, tiny little depressions at the ends of the fingers. And let's not forget the calcinosis cutis, which is the C of crest.
Calcinosis cutis, those are the calcium deposits in the soft tissues.
Yes. They occur most often around joints and tendons, particularly in the hands. They cause significant disability, chronic pain, and when they ulcerate through the skin, they create these portals for infection that are very, very hard to manage. It's a hallmark of the long-term limited disease profile.
We have to turn our focus inward now because this is where SSC causes the most mortality. The lungs are arguably the most important organ to monitor in this disease.
The pulmonary system involvement is, without a doubt, the leading cause of SSC-related mortality. Over 80% of patients will have some degree of involvement, which generally falls into two distinct categories.
Let's take the first one. The fibrosis, interstitial lung disease, or ILD.
ILD is the scarring of the lungs. It's characterized by progressive breathlessness on exertion and a persistent dry cough.
And there's a hallmark sound that a clinician listens for.
Yes, and it's striking. We listen for Velcro rails at the lung bases.
Velcro rails? That's such a vivid, descriptive term. So you're saying a clinician can literally hear the sound of the stiff, fibrotic lung tissue being forced open during inhalation?
That's exactly right. It sounds just like pulling apart Velcro. It's a classic physical examination finding that strongly suggests interstitial lung fibrosis is present. And ILD significantly restricts oxygen exchange, which eventually leads to respiratory failure.
And the second major type of lung disease is the vascular problem, pulmonary arterial hypertension, or PAH.
PAH is a killer. It occurs in a significant minority, somewhere between 10 and 40% of patients. Yeah. And it's particularly common in the limited cutaneous subset LCSSC, often even without severe ILD.
So this is high blood pressure specifically in the arteries supplying the lungs.
Exactly. The heart has to work much harder against this resistance. which leads to right-sided heart failure, what we call cor pulmonale. Vessel thrombosis, or clotting, in those affected pulmonary arteries is a critical late-stage complication and a frequent cause of death.
Okay, so if the lungs are the leading cause of death, the gastrointestinal tract is arguably the most frequently involved system.
It is. It's affected in nearly 90% of all SSC patients. The esophagus is involved most frequently, often leading to chronic reflux, severe heartburn, and difficulty swallowing, dysphagia, due to reduced peristalsis and sphincter function.
And that chronic reflux isn't just uncomfortable, it links back to those deadly lung complications.
It absolutely does. Recurrent episodes of what we call microaspiration, so tiny amounts of stomach acid reaching the lungs, may actually contribute to the development or progression of ILD. It provides a constant low-grade injury to the lower airways.
What about the rest of the GI system, the lower tract?
The lower GI tract involvement causes significant morbidity. We see alternating constipation and diarrhea, episodes of pseudo-obstruction where the bowel motility is severely compromised.
So the gut just stops moving properly.
It does. And that stasis leads to subsequent bacterial small bowel overgrowth. This overgrowth leads to chronic malabsorption and nutritional deficits, which contribute to overall weakness and frailty.
You also mentioned a distinct vascular feature in the GI tract, the watermelon stomach.
That's the colorful name for antral vascular acacia. It's characterized by these radiating stripes of dilated blood vessels in the lower part of the stomach. During an endoscopy, it looks just like a watermelon stripe pattern.
And what's the clinical significance of that?
Its clinical significance is chronic, slow GI bleeding, which often leads to an unexplained iron deficiency anemia that requires continuous management.
Let's move now to the musculoskeletal system. I imagine pain and stiffness are common, but there is one specific clinical sign that should immediately raise alarm bells for a clinician examining a patient with diffuse SSC.
That sign is tendon friction rubs.
Okay, what is that?
This is a palpable or even audible coarse crepitus, a grating or crunchy noise that's heard or felt over joints like the fingers, wrists, elbows, knees, or ankles.
You can actually hear it.
You can with a stethoscope, and you can certainly feel it. This is a classic marker of diffuse disease. Its presence signals aggressive, rapidly advancing systemic disease, and it's a known predictor of major organ involvement, especially scleroderma renal crisis.
That's powerful. The physical examination holds immediate life and death prognostic information. Speaking of which, let's detail that complication. Scleroderma renal crisis, or SRC?
SRC is an acute, terrifying development. It occurs in up to 10% of SSC patients and almost exclusively in the early stages of diffuse disease. It is a true vascular emergency in the kidneys.
How does it present clinically? What are the signs?
The classic presentation is an abrupt onset of marked, often malignant hypertension combined with a rapidly progressing oliguric kidney failure, meaning the patient stops making urine.
And what's happening at the microscopic level?
The underlying mechanism involves damage to the small renal blood vessels. This leads to something called microangiopathic hemolytic anemia, where red blood cells are literally shredded as they pass through the damaged vessels, and thrombocytopenia, which is a low platelet count.
It's important to clarify, though, that while SRC is the acute disaster, chronic kidney issues are also present in many patients, right?
That's correct. Up to 50% of SSC patients show some subtle signs of kidney impairment, like microalbuminuria. But these chronic changes usually remain stable. SRC is the distinct, acute, high-mortality event that requires immediate, non-immunosuppressive intervention.
Before we move on, let's just quickly touch on the other systemic manifestations, starting with the neuromuscular side.
Muscle atrophy or sarcopenia and myopathy are major contributors to morbidity and functional decline. We often see an inflammatory myopathy that closely resembles polymyositis. We also see very high rates of sexual dysfunction,
Which, while often neglected in clinical discussion, severely impacts quality of life.
Absolutely. In males, erectile dysfunction is extremely common, affecting over 80%, and it often acts as one of the earliest vascular signs.
Well, what's the mechanism there?
It stems from impaired penile blood flow and fibrosis of the corporal tissues. Females face issues like dyspareunia or painful intercourse due to decreased vaginal lubrication and introitus constriction caused by localized fibrosis.
Finally, we should flag the increased association with other non-SSC-related health risks.
Yes, there's a documented increased malignancy risk, notably lung cancer and esophageal carcinoma.
Esophageal cancer.
Yes, for esophageal cancer, the standardized incidence ratios can be alarmingly high, up to 16 in some cohorts.
16 times the normal risk.
It suggests that the chronic tissue damage and inflammation, perhaps from that chronic reflux, provides a fertile ground for malignant transformation. There's also a heightened threefold risk of venous thromboembolism, or VTE, especially in the first year after diagnosis, which further complicates management.
Okay, here's where it gets really interesting. We've established the destructive effects of SSC, the fibrosis, the organ failure. Now let's dive into the pathogenic puzzle. Why do some people develop this precise, multi-system assault? Genetics clearly loads the gun.
Genetics is absolutely fundamental, but SSC is not a simple Mendelian inherited disease. It's not like if your parent has it, you'll get it. It's about increasing susceptibility.
So it's not deterministic.
Not at all. The genetic factors massively influence who gets the disease and, crucially, what flavor of the disease they develop.
And the strongest genetic links consistently point to the immune system's core recognition machinery.
Exactly. The most powerful associations lie within the major histocompatibility complex, or MHC. This is the part of our genome that controls how the body recognizes self versus non-self.
Can you give an example?
A great one is in the Choctaw Native American population. They have a prevalence of SSC that's 20 times higher than the general population.
20 times?
And in that group, the presence of specific antibodies, like anti-sapoisomerase IR, is tightly linked to a specific HLA haplotype DQ7-DR2, and specifically the allele DRB11-CINZO2.
That is a highly specific genetic vulnerability. It tells us it's not just a general genetic susceptibility, but a very precise interaction.
It does. And beyond those HLA genes, we see major associations with non-HLA genes that often overlap with other autoimmune disorders like lupus or SLE. This shows a shared malfunction in the immune signaling pathways.
What are some of the key non-HLA genes that give us a window into this immune malfunction?
Well, we look at genes like IRF5 and STAT4.
Okay.
These are both transcription factors. They're like master switches that are implicated in inflammatory signaling.
And what's their role in SSC?
Well, IRF5 and STAT4 polymorphisms are known to increase the risk for lupus, and in SSC, polymorphisms in STAT4 have shown an additive effect with IRF5 polymorphism.
Your additive effect.
Yes, together they significantly increase the risk of interstitial lung disease.
So, if a patient has two genetic Strex polymorphisms in both IRF5 and STAT4, they are exponentially more likely to develop that deadly lung fibrosis.
That's the implication. We also see genes involved in T-cell activation, such as PTPN22 and CD247. What's truly intriguing, though, is that the majority of these genetic variants associated with SSC are located not in the coding regions that make proteins,
but in the non-coding regions, the regulatory parts.
Exactly, the so-called junk DNA. This means their exact contribution is about regulating when, where, and how much a gene is turned on or off, which makes the pathogenesis highly nuanced.
Okay, so we have a genetically susceptible individual. What pulls the trigger? What evidence do we have for external factors initiating SSC?
The environmental hypothesis is very robust. We have clear data linking occupational and toxic exposures to disease onset, particularly in the male population.
Let's start with the one that's been known for a long time. Silica.
Occupational silica exposure, the crystalline dust you find in mining, sandblasting, stonemasonry, is one of the earliest recognized and strongest associations. A major meta-analysis found the estimated relative risk for SSC in males exposed to silica was 3.0, so threefold increased risk.
Why is that link so potent in males compared to females?
That's still unclear, but the evidence is compelling. Silica seems to activate macrophages and fibroblasts directly, promoting both inflammation and fibrosis.
And beyond dust, there are chemical toxins and solvents that seem to provoke SSC-like reactions.
Indeed. We've seen implicating evidence for organic solvents like trichloroethane, toluene, xylene, and various paint thinners. But perhaps the most illustrative example is the SSC-like disease reported in individuals exposed to vinyl chloride monomer.
The chemical used in plastics manufacturing?
Right. These patients developed Raynaud phenomenon and nail fold changes, confirming that immediate vascular toxicity, but sometimes without the full clinical picture of SSC.
This brings us to the historical natural experiments, the epidemics of SSC-like disease that resulted from mass toxin exposure.
They provide invaluable comparison data. First, you had the toxic oil syndrome in Spain in the 1980s. This was caused by contaminated rapeseed oil.
What did that look like?
It caused an acute multi-system illness involving myalgia, fever, neuropathy, SSC-like skin disease, and severe PAH. Then there was the eosinophilia myalgia syndrome in the U.S. in the late 1980s, linked to a contaminated L-tryptophan supplement.
Did those two conditions meet the full definition of SSC?
This is the crucial part. They are so important because of their differences. While the L-tryptophan patients developed chronic diffuse skin induration and fasciitis, they critically lacked the core SSC features.
What's missing?
No Raynaud phenomenon, no SSC-specific autoantibodies, and no typical visceral disease. This absence shows us that while a chemical exposure can definitely trigger profound fibrosis, the specific SSC pathogenesis requires additional factors, perhaps related to T-cell activation, that these specific toxins didn't activate.
Okay, what about the idea that an infection, like a latent virus, might trigger the immune cascade, the molecular mimicry theory?
The theory suggests that a virus, perhaps something like cytomegalovirus or CMV, has protein sequences that closely mimic those of our own host proteins.
So the immune system gets confused.
Exactly. When the immune system attacks the virus, it mistakenly attacks the host tissue too, initiating autoimmunity. CMV is a strong candidate because it can infect endothelial cells, promoting vascular injury, and it can directly stimulate profibrotic factors like TGF-beta. It provides that unique blend of vascular, fibrotic, and immunologic stimulation that SSC seems to require.
And the microchimerism hypothesis, the body creating an immune response against cells from a pregnancy, that sounds like the most unusual external trigger of all.
It's certainly complex. Microchimerism involves the persistence of a small number of fetal cells in the maternal circulation in tissues for years or even decades after a pregnancy.
How did this idea come about?
The hypothesis gained traction because SSC shares so many clinical features, the skin, lung, and GI fibrosis, with a condition called chronic graft versus host disease, or GVHD.
So the idea is that the persistent fetal cells, the graft, might mount a subclinical immune response against the mother, who is the host.
Exactly. It's a hypothesized variant of GVHD.
Oh.
And studies have found increased levels of fetal cells in the blood and tissues of women with SSC after pregnancy, compared to healthy controls.
So there's evidence for it.
There is some, yes, which lends credence to the idea. However, the exact mechanism, whether it's the fetal cells causing the damage or the mother's immune system reacting against those cells, that remains an active area of investigation, and not all studies have confirmed the finding.
All of these complex triggers eventually lead to the clinically actionable part of the puzzle, the autoantibodies. These tiny markers in the blood are essentially the GPS system for this heterogeneous disease.
They absolutely are. They're the most crucial prognostic tools we have available.
It starts with the ANA, right?
Yes, almost all SSC patients, about 95%, are positive for the anti-nuclear antibody, or ANA. But the SSC-specific autoantibodies are incredibly specific. They provide far better predictive power for organ involvement and survival than the physical classification of limited versus diffuse skin disease alone.
Okay, let's synthesize the three major high-risk antibodies, starting with the one that's associated with the most significant internal fibrosis.
That would be anti-CL70, which targets an enzyme called topoisomerase I.
CL70.
Found in 10 to 40% of patients, it is the classic hallmark of diffuse cutaneous SSC, DCSSC, and it signifies a substantial risk of severe interstitial lung disease.
So if CL70 is positive?
If CL70 is positive, the clinician must assume ILD is either present or imminent and monitor aggressively.
Conversely, we have the antibody associated with the classic limited form.
That's the anticentromere antibody, or ACA. It's seen in 15 to 40% of patients. ACA is the defining feature of LCSSC, the limited form.
And what's their risk profile?
These patients have a high risk of developing pulmonary arterial hypertension, PAH, and severe esophageal disease. But critically, ACA positivity is often described as protective.
Protective. How so?
It rarely coexists with severe kidney or lung fibrosis, which distinguishes it dramatically from CL70.
So, the autoantibodies are the true GPS map of SSC, often overriding the physical skin presentation. Now, let's talk about the one that's a warning sign for disaster, anti-RNA polymerase III.
This antibody, found in 4 to 25% of patients, is tied to two of the most life-threatening acute conditions. It is strongly linked to DCSC, very rapid skin progression, and an exceptionally high risk of scleroderma renal crisis.
Wait, I remember you mentioning a link between this antibody and malignancy earlier.
Yes, that's right. There is a close, recognized temporal relationship between the onset of cancer, particularly lung, skin, and breast cancers, and SSC in patients who are positive for anti-RNA polymerase III.
So what's the thinking there?
The research suggests that tumors with somatic mutations in a gene called PUL-R3A, may release antigens that trigger the production of these autoantibodies. This makes the antibody itself a paraneoplastic marker, a sign that a cancer is either present or about to develop.
And we must mention the anti-TH2 antibody because it singles out a very specific long-term risk.
Anti-THATO, though seen in a smaller group, maybe 1 to 7%, is critical. Retrospective studies have shown that patients with this antibody face a 3.3-fold substantially increased risk of developing pulmonary arterial hypertension within 10 years.
Which leads to reduced survival.
It does. It forces an aggressive long-term monitoring strategy for the pulmonary vasculature, even if the patient seems stable otherwise.
This incredible specificity brings us right to the core of the problem, the fibrotic process. How does this excessive hardening happen at the cellular level, and why does it become so aggressive and unstoppable?
It's a complex molecular loop. It begins with damage to the vascular endothelium, the lining of the blood vessels. This damage activates the endothelial cells to release potent vasoconstrictors like endothelin-1, ET1, and to upregulate adhesion molecules.
So the vessels are damaged, they constrict, and they put out this molecular welcome mat for immune cells.
Precisely.
Yeah.
Immune cells, T cells, B cells, macrophages, they adhere to that sticky vessel lining and migrate into the surrounding tissue where they kick off the inflammatory process. But the central actor, the one doing the physical scarring, is the fibroblast.
This fibroblast is our construction crew, and the immune cells are the site foreman's screaming instructions. What are the key chemical messengers that make them overproduce collagen?
The most famous contractor in this scenario is transforming growth factor beta, or TGF-beta.
TGF-beta.
It is central to all fibrosis. It, along with platelet-derived growth factor, PDGF, and connective tissue growth factor, CTGF, drives the massive overproduction and synthesis of collagen.
And we need to connect the vascular damage back to the fibrosis here. Does that vasoconstrictor ET1 have a role beyond just vessel constriction?
It absolutely does. Endothelin-1 is a potent vasoconstrictor, yes, but it is also highly fibrogenic. It directly stimulates fibroblasts to produce collagen.
So it's a double whammy.
It creates a devastating molecular link where vascular injury immediately feeds the fibrotic process. And elevated ET1 levels are found in both the fibrotic and the primary vascular subsets of SSC.
But the truly defining and I think frustrating characteristic of SSC fibroblasts is their autonomy. They become independent of external signaling.
This is the crux of why the disease is so refractory to treatment. In healthy tissue, fibroblasts stop producing collagen when the repair job is done. SSC fibroblasts, however, they retain their aggressive, high collagen-producing phenotype even when you isolate them and culture them in a dish, away from all the immune cells and chemical signals.
So they are essentially self-sustaining. Why? How does that happen?
It suggests an intrinsic stable change has occurred. Possible mechanisms include failures in inhibitory pathways, like the inability to use something called SMAD7 to block TGF-beta signaling, or perhaps impaired degradation of the TGF-beta receptors themselves.
Or something even more fundamental.
Crucially, there is strong evidence for stable epigenetic changes, things like hypermethylation of DNA in regions of key regulatory genes. These changes essentially lock the fibroblast into the on state. It makes them less capable of sensing and responding to cues from the extracellular matrix that should be telling them to stop building.
And this granular understanding of the autonomous loop is why the therapy focus is shifting toward blocking specific cytokines.
Yes, exactly. The focus on interleukin-6, or IL-6, has intensified. Studies show higher serum IL-6 levels are strongly associated with severe skin disease and the progression of lung fibrosis.
So the idea is to block IL-6.
The concept is that IL-6 modulates other profibrotic pathways in the fibroblasts. So blocking IL-6 signaling with agents like tocilizumab has shown potential antifibrotic effects. It seems to reduce the profibrotic signature in certain macrophages in the skin, which suggests we might be able to dial back the construction crew.
Any other target?
We also observed that elevated plasma levels of a chemokine called CXCL4 correlate strongly with faster progression of both skin and pulmonary fibrosis, making it another potential target for future therapies.
Now we transition from the mechanism to the clinical reality. If a patient walks in with seemingly disparate symptoms, Raynaud, puffy hands, GI issues, how does a clinician systematically connect those symptoms into the definitive SSC diagnosis? What does that diagnostic roadmap look like?
The diagnosis starts with a high level of clinical suspicion, which leads to early referral. SSC is a diagnosis of pattern recognition, the presence of characteristic clinical findings that are then supported by highly specific serologic abnormalities.
What are the essential physical examination tools used to quantify the fibrosis?
Clinicians primarily rely on the Modified Rodnan Skin Score, or MRSS.
The skin score.
Right? It's an objective tool used to semi-quantify skin thickness. We score severity from 0, which is normal, to 3, most severe, across 17 distinct body areas. This gives a maximum score of 51. And tracking this score over time is vital for measuring therapeutic response.
Beyond the skin score, what simple visual inspection is critical?
Nail fold capillaroscopy. This involves looking at the capillaries at the base of the fingernail with a magnifying scope. An experienced clinician looks for highly characteristic abnormalities.
Like what?
Dilated capillary loops and capillary dropout, which are areas where vessels have been destroyed. This is a vital sign of underlying microvascular damage. And of course, the clinician actively seeks out those tendon friction rubs.
Because their presence instantly elevates the patient to the highest risk category.
Instantly.
The laboratory evaluation is where the specific roadmap is really revealed.
Exactly. Routine labs check for basic systemic involvement, anemia, creatinine elevation, muscle enzyme levels. But the most critical component is that serologic panel. Once the ANA is confirmed positive, which it is in 95% of cases, we drill down into the SSC-specific, highly predictive autoantibodies.
The CL70, ACA, RNA, POL3.
And anti-theta-DO. These not only confirm the diagnosis, but they dictate the entire screening schedule.
Given that SSC mortality is dominated by lung and cardiac issues, evaluation of those systems must be mandatory for every suspected patient, even if they aren't complaining of breathlessness yet.
It is non-negotiable surveillance. All patients must be evaluated for both ILD, the fibrosis, and PAH, the vascular disease. For ILD, we start with pulmonary function testing, or PFTs.
What are you looking for there?
We look for restrictive defects and a decreased diffusing capacity of the lung for carbon monoxide, or DLCO. That DLCO is a powerful predictor of early vascular involvement in the lungs.
And what gives us the clearest picture of the actual damage?
That would be a high-resolution computed tomography, or HRCT, of the lung. This frequently reveals subtle interstitial lung abnormalities, even in patients whose PFT results are still within the normal range.
And for the heart?
For the heart, a Doppler echocardiogram is the standard initial screening tool for potential PAH.
So once the diagnosis is confirmed and classified limited, diffuse, or sign scleroderma, how does the management strategy guide that highly individualized treatment?
The management is entirely organ-based and risk stratified by those autoantibodies. The overriding principle is that treatment must be initiated early to slow progression before irreversible fibrotic damage sets in.
So you treat the symptoms?
We treat reflux with PPIs, Raynaud with calcium channel blockers. But the one rule that applies to everyone is the warning against a very common rheumatology tool: steroids.
The glucocorticoid warning. This is crucial. High doses must be avoided.
Absolutely. This is a critical clinical nugget. High-dose glucocorticoids, specifically prednisone doses of 15 milligrams daily or greater, are documented to precipitate scleroderma renal crisis.
So you're treating the inflammation at the cost of causing a life-threatening vascular emergency in the kidney.
That's the risk. Low, short-term courses, say less than 10 milligrams daily, might be used cautiously for refractory inflammatory joint pain, but the risk must always, always be weighed.
Let's focus on the management of the fibrosis itself, both skin and lung. What are the first-line systemic immunosuppression choices for aggressive disease?
For aggressive diffuse SSC, or associated ILD, we start with systemic immunosuppression. Typically, that's either methotrexate, MTX, or mycophenolate mofetil, MMF.
How do you choose between them?
The choice is often dictated by the dominant manifestation. MMF is generally preferred if ILD is the primary concern. It has a strong safety profile for lung tissue, and it's highly efficacious. MTX is often preferred if the patient is suffering more from arthritis or inflammatory myositis.
And what happens when patients are refractory to those initial therapies, when they don't work?
For resistant skin sclerosis or progressive ILD, we escalate to targeted biologics. Agents like rituximab, which is a B-cell depleting agent, or tocilizumab, the IL-6 receptor blocker, are increasingly used.
And tocilizumab is the one that targets that IL-6 loop.
Exactly. It has shown efficacy against both skin and lung fibrosis in early active disease, stemming from its ability to disrupt that profibrotic loop we discussed.
Shifting to symptomatic management, how do we handle those painful chronic physical manifestations like the calcium deposits?
For calcinosis cutis that's causing ulceration or chronic infection, we suggest a course of oral minocycline for 6 to 12 weeks. It's been shown to reduce the calcium burden and decrease inflammatory symptoms.
And surgery.
Surgical removal is a last resort. It's reserved for cases that cause severe functional disability or chronic infection, mainly due to the high risk of poor wound healing and sclerotic skin.
And for that intense pruritus, the itching.
Topical emollients are a necessity. Beyond that, we use counter-irritants like capsaicin or menthol and oral antihistamines. Sometimes low-dose short-term corticosteroids are used here, but again, with extreme caution.
Back to the vascular emergencies. We synthesized the SRC risk. Let's clarify the treatment strategy for it.
Scleroderma renal crisis is a vascular emergency, not a typical inflammatory flare. Therefore, the treatment is non-immunosuppressive. It relies primarily on aggressive management with ACE inhibitors.
And that's critical.
It is life-saving. ACE inhibitors are highly effective in this context, even if they might be contraindicated in other forms of renal failure.
And for the high prevalence of male erectile dysfunction, what is the preferred treatment approach?
Because the dysfunction is often rooted in structural microvascular damage and fibrosis of the corporal tissue, on-demand treatments are less effective.
So what's the alternative?
The preferred strategy is a fixed daily or alternate-day regimen of long-acting PDE5 inhibitors, something like tadalafil. This helps maximize chronic blood flow and maintains tissue oxygenation.
We have to finish with the long view, monitoring and prognosis. We established that SSC patients face a substantial increase in mortality risk, an SMR of 3.5. How do we monitor for the biggest killers?
Surveillance is rigorous, and it's individualized based on the disease subset and that autoantibody profile. Since the majority of deaths stem from pulmonary fibrosis, PAH, or cardiac causes, monitoring the lungs and heart is paramount, especially in the first 5 years, when disease progression is usually fastest.
Walk us through the monitoring schedule for the lungs.
For ILD, we require annual PFTs for at least the first 5 years after diagnosis. If function remains stable for 3 years, we might decrease the frequency.
And for PAH surveillance?
In addition to the annual echocardiogram, we utilize a biomarker. We check annual plasma NT-proBNP levels for high-risk patients.
Who are the high-risk patients?
Those with SSC duration longer than 3 years or those with a low DLCO on their PFTs. An elevated NT-proBNP suggests the right side of the heart is straining, and it should trigger further, more invasive investigation.
And for the dreaded SRC, what level of vigilance is required?
SRC surveillance requires daily attention. Patients designated as high risk, so those with early diffuse disease, rapidly progressing skin, especially with those tendon friction rubs, or those positive for anti-RNA polymerase III, they must check their blood pressure daily.
Every single day.
Every single day. We instruct them that any sustained increase of 15 mmHg systolic or 10 mmHg diastolic requires immediate communication with the clinic for evaluation, as it could be the very first sign of a crisis.
Finally, let's synthesize the biggest takeaways regarding prognosis. What are the strongest overall predictors of a high mortality risk?
The clinical factors are extensive skin involvement, so a high modified Rodnan skin score male sex, and a younger age at disease onset. But the molecular factors, the antibodies, they are often better long-term predictors of survival and specific organ failure.
So which ones are the worst?
Positivity for anti-topoisomerase I, the SKIL70, anti-TH2, or anti-RNA polymerase III antibodies places that patient in the highest mortality risk category and necessitates the most aggressive surveillance protocol we have.
We've navigated this extremely challenging landscape. We've seen how systemic sclerosis transitions from a seemingly localized hardening, that initial scleros, to this complex systemic assault.
It's the body's own immune system, the damaged blood vessels, and those overactive autonomous fibroblasts, all conspiring to turn soft tissue rigid.
And this deep dive really confirms that personalized risk assessment, driven by the predictive power of those autoantibodies, is vital.
It is. It allows clinicians to predict whether a patient is heading toward PAH, severe ILD, or an acute renal crisis, and then tailor aggressive surveillance to match that risk profile.
This raises an important question.
Given the significant and shared genetic susceptibility loci for SSC, for lupus, and for other autoimmune conditions, those overlapping genes like IRF5 and STAT4, and given the repeated and powerful links between environmental triggers like silica, organic solvents, and latent viruses, the central question for future research isn't just how to reverse the fibrosis that's already established.
So it's not just about treatment.
No, it's about identifying the precise moment and the precise mechanism by which that environmental factor switches on a pre-programmed genetic vulnerability, initiating the entire pathological cascade in the first place.
find the switch.
If we can isolate that switch, we move beyond reactive management and might achieve true primary prevention of these devastating systemic diseases entirely.